Welcome to this microlearning session on initiating the rapid response team, brought to you by the patient safety coordinators. The objective of the rapid response team is to identify, assess, and treat deteriorating medical conditions before resuscitation is required. They will respond within 10 minutes of being called. They facilitate timely escalation to higher level care. They assist with communication between the nurse and the provider, and they educate and support the bedside staff.
Because we want to ensure that we're using our resources wisely, the rapid response team is not supposed to replace consultations with responsible care providers, and it's not for bypassing the chain of command. If your patient has any airway incompetence, examples are angioedema, food obstruction, foreign object obstruction, poor management of secretions, or you hear stridor, this should alert you to call the rapid response team.
Call a rapid response if your patient has new onset of difficulty breathing or needs oxygen of 60% or greater. If they have acute worsening of oxygenation saturation despite oxygen administration. If your patient has a respiratory rate less than 10 or greater than 30 per minute for 5 minutes, or if they exhibit signs of increased work of breathing.
You'll want to initiate the rapid response team if your patient's heart rate is under 40 or over 120 with signs of impaired blood flow or organ dysfunction, or if their systolic blood pressure is under 90 or over 200 with signs of impaired blood flow or organ dysfunction, like clammy skin, weak pulses, decreased urine output, delayed capillary refill, or altered mental status.
You would also want to initiate the rapid response team if your patient is having a suspected stroke, repeated or prolonged seizures, unexplained agitation, or unexplained decreased level of consciousness.
You can call the rapid response team if your patient is having a hypoglycemic event, which is under 50 with 2 readings an hour apart. If you have concern about any physiological deterioration of the patient that doesn't fit the above items mentioned, or if you have a fall with confirmed.
When activating an RRT on mobile heartbeat, type 155 and select 155BH only for Bridgeport campus and 155MC only for Milford campus. Your role and responsibility as the primary nurse is to remain at the bedside as a member of the team, support the RRT nurse with vital signs and medication administration as needed, review with the RRT the last 4 hours of vital signs, assessment, and medication, call for any additional equipment, and if you're not the primary nurse, ask what can I do for the other patients. If you're the charge nurse, you should broadcast the RRT that's occurring on the unit, and if the patient will be transferred, you should be providing report to the receiving nurse.
Let's review a case study of a patient who arrives to the unit from the MICU. This is a 79-year-old female arriving to the unit at 11 a.m. Vital signs is a blood pressure of 162/74, a heart rate of 82, SpO2 of 96, unwarm air, respiration is 22, and a temperature of 100.8. At 11:15, you message the provider on your mobile heartbeat regarding the elevated respirations and temperature. The message is read, but no response.
At 13:30, you cycle a blood pressure before giving metoprolol, and it reads 98/60 and a heart rate of 115. The provider is alerted of the change in blood pressure, and the metoprolol is administered. Again, the message is read, but no response. At 16:35, the nurse completes an EKG, which shows normal sinus rhythm 120. The provider is messaged again to report elevated heart rate and whether the RRT should be activated. The message was read, but no response again.
At 1700 hours before administering Lasix, the nurse notes a rapid breathing, but the patient doesn't complain of shortness of breath. Vital signs is a blood pressure of 88/50, heart rate 128, SpO2 93 unwarm air, a temperature of 102.8, At this time, the rapid response team is activated and the patient is worked up for sepsis.
Based on this case, what additional resources do you have for early recognition of clinical decline?
You could talk to your charge nurse or you can call SWAT for guidance.
Who should the nurse have reached out to after the resident read the message but did not respond to it?
If the resident was not responding within a reasonable amount of time, the call could be escalated to the attending and up the chain of command for a medical problem.
What were some signs the patient was presenting with prior to the RRT activation that indicated a decline?
The patient had respirations of 22 and a fever that could indicate early sepsis. The low BP of 98/60 and increased heart rate of 115 also warrants calling an RRT. The take-home message is that you can arc up your concerns, and anytime you have a delay in response, we need to capture that in an incident report with an RL so that it can be addressed. Thank you for watching. We appreciate your participation.